Welcome to the Hospital Medicine Unplugged podcast.
Great to be here.
Today we're tackling a really critical topic, the evidence-based, multidisciplinary management of massive hemoptysis. It's one of those high-stakes, thankfully low-incidence emergencies, but when it happens, minutes absolutely matter.
They really do. And our goal today, I think, is to try and synthesize the current guidelines. We're pulling mainly from the American College of Chest Physicians, the ACCP, and also the American College of Radiology, the ACR, trying to create a sort of unified, actionable approach for us physicians on the front lines.
Exactly. Because managing this is, well, it's intense.
It is. And this synthesis is so important, especially because the actual risk, the definition itself, can sometimes be misunderstood. We often think of the quantitative definition first.
Right, volume. Like expecting more than, 200 milliliters of blood in 24 hours?
Typically, yes, that's the classic number, 200 milliliters or more. But honestly, as hospitalists, as critical care folks, we have to focus on the functional definition, meaning any amount of bleeding, regardless of the measured volume, that starts to compromise the patient's respiratory status or their hemodynamic stability, that's massive hemoptysis. And that needs immediate aggressive intervention.
That makes sense. So it's not just about the number, it's about the physiological impact.
Precisely. And that functional definition, that really dictates our entire priority list, doesn't it?
It does, because we're not primarily worried about them bleeding out, exsanguination, although, that could certainly play a role, especially if there's a coagulopathy.
Sure, it contributes. But the fundamental danger, the main thing that kills these patients, is asphyxiation.
Drowning in their own blood, essentially.
It sounds brutal, but yes. The physics of it are actually terrifyingly simple. Even a relatively small amount of blood, maybe just 100 milliliters, can spread incredibly quickly into the distal airways, into the alveoli.
And that blocks gas exchange.
Right. It leads to acute airway obstruction, severely impaired gas exchange, and just profound hypoxemia. This rapid alveolar flooding, if you don't intervene immediately, it inevitably leads to cardiovascular collapse. So, when we talk massive hemoptysis, we are literally fighting the clock to keep that airway open and prevent that fatal drowning.
Okay, so let's walk through those first few critical minutes. Picture the scene. The patient's crashing, maybe in the ED, maybe the ICU. Before we even figure out the why or the definitive fix, what are the absolute must-do steps for immediate stabilization?
Okay, number one priority, always, always, always. Protect the airway. It starts with lightning fast assessment. Is the airway patent? What's their oxygenation? What are their hemodynamics doing?
So what are the red flags for grabbing that airway?
Any signs of impending respiratory failure. So altered mental status is a big one. Severe respiratory distress. Accessory muscle use, gasping, or, crucially, if they simply cannot clear their secretions, if they're gurgling, choking on blood. Any of those mandate emergent endotracheal intubation, no question. That decision right there is often the single most critical one we make.
And when we intubate in this specific situation, just grabbing a standard tube might not be ideal, right? The choice of tube, the technique, it matters for managing the bleed itself.
Absolutely critical. You really want to use a large bore, single lumen cuffed endotracheal tube. We generally aim for an internal diameter of 8.0 millimeters or even larger if possible.
Why so big?
The large bore is vital because you need to be able to get a therapeutic bronchoscope down there later. You need that larger channel to effectively suction out the massive blood clots that are inevitably present.
Okay, makes sense. And the cuff?
The cuff is non-negotiable. You absolutely need that seal. It does two things. Protects the non-bleeding lung from aspiration, from blood spilling over, and it allows for effective positive pressure ventilation if needed.
Now, what if we actually know where the bleeding is coming from? Let's say we have a patient, known history, big aspergilloma in the left upper lobe, clearly bleeding from there. Does that change the intubation strategy? Is selective intubation something we should consider?
Yes. If you definitively know the bleeding side, and that's a big if in the chaos, then selective mainstem intubation is a really powerful temporizing measure.
How does that work?
You intentionally advance the endotracheal tube further down into the mainstem bronchus of the non-bleeding lung. So if the left side is bleeding, you intubate the right mainstem. This completely isolates the good lung, protects it.
Buys you time.
Exactly. It buys critical time, but it requires a very skilled operator, often with bronchoscopic guidance, and it does limit what you can do therapeutically in that intubated mainstem later. And the big caveat, honestly, is that figuring out the bleeding source definitively when the patient is actively crashing It's incredibly difficult, often makes this maneuver impractical in the real world.
That difficulty in localization really highlights the importance of something simpler. Patient positioning. It sounds basic, but it's physiologically crucial.
It's probably the easiest, quickest intervention we have, and it can make a huge difference. If you can identify the bleeding side, maybe from history, maybe a quick look at a portable chest x-ray, or even just auscultation, the patient absolutely must be placed in the lateral decubitus position.
Which side down?
Bleeding lung dependence, bleeding side down. Gravity is your friend here. It helps keep the blood pooled in the affected lung, minimizing the spillover across the carina into the contralateral healthy lung. That significantly reduces the risk of asphyxiation.
And if we have no clue where the bleeding is?
If the source is completely unknown, then keeping the patient supine is generally acceptable until you can get better localization, usually with emergent imaging or bronchoscopy. But side down is preferred if you know.
Okay, so airway secured, maybe positioned appropriately.
Yes.
At the same time, we have to deal with circulation and stopping the bleeding, right?
Yes, absolutely. The resuscitation phase happens concurrently. Supplemental oxygen immediately, high flow. If hypoxemia persists despite that, you move to mechanical ventilation. You need large bore IV access, think 16 gauge or larger, preferably 2 lines. We need to be ready for volume resuscitation, possibly blood products, because while asphyxiation is the main killer, significant blood loss leading to hemodynamic instability to shock certainly contributes to mortality.
And you mentioned stopping the bleeding. Let's pivot to what needs doing right away regarding coagulation. That often feels like the low-hanging fruit, doesn't it?
It is, and it must happen simultaneously with airway stabilization. You cannot wait. Reversal of any underlying coagulopathy is just a core principle here.
So someone's on warfarin.
Immediate correction is mandatory. That means vitamin K, absolutely, but that takes hours to work. So you need factor replacement now, either fresh frozen plasma, FFP, or prothrombin complex concentrate, PCC.
FFP versus PCC. Any preference?
Well, PCC is generally faster. It's a lower volume load, which can be helpful in fluid-sensitive patients. But you have to remember, standard 4-factor PCC lacks significant amounts of factor V, which FFP contains. Factor VIII is also lower. In a massive bleed scenario, the speed of TCC often wins out, but you need to be aware of what it doesn't have.
And thrombocytopenia.
If the platelet count is low, say below 50,000 or maybe below 100,000 if they have other reasons to bleed or are undergoing a procedure, platelet transfusion is necessary. You need enough platelets for primary hemostasis.
What about the newer drugs, the direct oral anticoagulants, the DOACs?
Yeah, that's increasingly common and presents a different challenge.
Yeah.
If the patient is on rivaroxaban or apixaban, the factor Xexin inhibitors, the specific reversal agent is andexanet alpha. Availability and cost can be issues, though. If they're on dabigatran, the direct thrombin inhibitor, the specific reversal agent is adarucizumab. If those specific agents aren't available, or if you don't know what they're on, supportive care, maybe activated PCC or AFib in some protocols, becomes the approach. But the principle remains. Identify and reverse iatrogenic coagulopathy immediately. Cannot wait.
Yeah, okay. Stabilization is underway. Airway, breathing, circulation, coagulation addressed. Now we can shift focus a bit to the clinical picture and figuring out the why. Beyond just coughing up blood, what are the classic signs we should look for that scream massive bleeding and decompensation?
Clinically, it's usually a pretty dramatic, acute onset, coughing up bright red, often frothy blood. Patients almost universally show signs of respiratory distress, marked dyspnea, significant tachypnea.
Breathing really fast.
Exactly. Using accessory muscles to breathe, you might hear stridor or gurgling sounds, especially if blood is pooling in the central airways. Hemodynamically, they might show tachycardia, a fast heart rate, trying to compensate.
Okay.
Hypotension can develop if blood loss is significant, or if the severe hypoxemia starts to cause cardiovascular collapse. It's often a picture of impending doom.
And that first chest x-ray, even though it's often limited in pinpointing the source, it still gives crucial prognostic information, right?
It absolutely does. While it rarely tells you which vessel is bleeding, the extent of pulmonary involvement you see on that initial film is a powerful risk stratifier. The ACR guidelines really emphasize this. If you see radiographic findings of opacification, basically whiteout, in 2 or more lung quadrants.
So significant portions of the lungs filled with blood.
Right. That finding is strongly associated with increased mortality. It signifies extensive alveolar flooding, meaning very little functional lung reserve left. That patient needs the most aggressive management pathway right now.
Let's dive into the etiology now. Knowing the source of the bleeding is key to guiding definitive therapy. You mentioned earlier that most life-threatening bleeds come from the high-pressure system. Can you elaborate on the difference between the bronchial and pulmonary circulation in this context? It's fundamental.
It really is foundational to understanding this. Okay, so you have two main circulations in the lung. The pulmonary circulation, that's low pressure. It carries deoxygenated blood from the right ventricle to the alveoli for gas exchange. Bleeds from this system, like from a pulmonary artery, are generally lower volume, lower pressure, unless a really major vessel is somehow eroded.
Okay.
Then you have the bronchial arterial system. This is completely different. It arises directly from the systemic circulation, usually branches off the descending thoracic aorta, sometimes intercostal arteries. These arteries supply the airways themselves, the bronchi, the supporting lung tissue, and crucially, they operate at systemic blood pressure.
So like 120/80 potentially, much higher pressure.
Exactly. Maybe a mean pressure around 100 millimeters of mercury compared to maybe 15 or 20 in the pulmonary artery. Now, what happens in chronic inflammation or with tumors or infections, the common causes of massive hemoptysis, is that these high-pressure bronchial arteries become hypertrophied, they enlarge, they get tortuous, twisted,
They become fragile.
incredibly fragile, and prone to rupture. When they rupture, you get massive high-velocity bleeding because it's coming straight from the systemic circulation. That's why the vast majority, probably 90%, of life-threatening hemoptysis cases are bronchial artery in origin. And that's why bronchial artery embolization, BAE, is the cornerstone of therapy.
Got it. Okay, let's break down those key etiologies then, starting with the most common ones globally, infections.
Yeah, infectious processes are definitely the front runners worldwide, primarily because they drive that chronic, intense inflammation that leads to bronchial artery hypertrophy we just talked about. Bronchiectasis is a prime example.
Regardless of the cause of the bronchiectasis.
Right, whether it's post-infectious, cystic fibrosis, whatever the underlying cause, you get these chronically inflamed, dilated airways, and they're supplied by these massive, fragile systemic collateral arteries. Perfect setup for a massive bleed. Tuberculosis is another huge one, especially globally. Both active TB and its long-term consequences, things like residual cavities, fibrothorax, are major drivers.
And you mentioned aspergilloma earlier. Fungal disease, what's the specific mechanism there?
So fungal infections, particularly aspergillosis, can form a fungus ball, that's the aspergilloma typically within a pre-existing lung cavity, often an old TB cavity. This fungus ball isn't invasive usually, but it sits there and mechanically irritates and erodes the cavity lining.
Right into those hypertrophied bronchial arteries.
Exactly, it just rubs away at them. Bleeding from an aspergilloma can be notoriously recurrent, often massive, and sometimes quite difficult to control with embolization alone, occasionally requiring surgical resection if it's localized and the patient is fit enough.
We're also seeing, maybe more frequently now, bacterial pneumonia as a cause of massive hemoptysis. That sounds particularly scary given how acute pneumonia is.
It is scary. And often this is linked to really destructive bacterial pathogens. Think certain strains of Staph aureus, especially MRSA or strep pneumonia, Klebsiella. These bugs can cause intense local tissue destruction, necrosis.
And that necrosis can erode into vessels.
Yes, it can erode not just into bronchi, causing bleeding that way, but it can also directly involve the pulmonary arterial system. You can get pulmonary artery pseudoaneurysm formation, basically a contained rupture of the pulmonary artery wall. This is a known dangerous complication of severe necrotizing pneumonia. It really highlights the need for immediate, appropriate, broad-spectrum antibiotics once you've got cultures, alongside controlling the bleeding invasively.
Okay, switching gears from infection to malignancy. When massive hemoptysis happens in a cancer patient, it often signals pretty advanced disease, doesn't it? And carries a grim prognosis.
Unfortunately, yes. Primary lung cancer, especially tumors located centrally near the main airways, like squamous cell carcinoma, is a critical etiology to consider. These tumors cause bleeding through several mechanisms. They develop their own fragile blood supply neovascularization. They can outgrow their blood supply and become necrotic, causing bleeding. Or, most critically, they can directly erode into a major central airway or even a great vessel like the pulmonary artery or aorta, creating an airway vascular fistula.
Which is often catastrophic.
Almost always. The prognosis here is indeed very poor. The ACCP guidelines note mortality rates for massive hemoptysis in the context of advanced malignancy can range anywhere from 59% up to essentially 100%. The anatomical destruction is often just too extensive for repair without incredibly high-risk surgery, if it's even possible.
Beyond infection and cancer, we also need to keep cardiovascular causes in mind, things like pulmonary AVMs or even left-sided heart disease.
Correct. Pulmonary arteriovenous malformations, AVMs, can be congenital or acquired. They're basically direct connections between pulmonary arteries and veins, high-flow shunts, and they are prone to rupture. Pulmonary artery pseudoaneurysms, as we mentioned with pneumonia, can also arise from trauma or other infections. But left-sided heart failure, specifically chronic severe mitral stenosis, is an interesting one.
How does that cause hemoptysis?
In severe mitral stenosis, you get backup of pressure from the left atrium into the pulmonary veins, leading to chronic pulmonary venous hypertension. This high pressure causes the pulmonary capillaries and also the bronchial veins, part of the low-pressure system, returning blood from the airways, to become engorged and rupture. So it's a different mechanism, often causing less massive but persistent bleeding. A careful history looking for rheumatic heart disease or known valve issues is really important.
And lastly, we can't forget the bleeds we sometimes cause ourselves in the hospital, iatrogenic causes.
Yes, unfortunately. Any invasive pulmonary procedure carries a risk. Transbronchial biopsies through a bronchoscope, percutaneous needle biopsies of the lung, even placing chest tubes or central lines if there's aberrant anatomy, all carry a risk of hitting a vessel. Blunt or penetrating chest trauma is another obvious cause.
And anticoagulation makes all this worse.
Exponentially worse. These acute iatrogenic or traumatic events become much more dangerous if the patient is already anticoagulated or has an underlying coagulopathy, which just brings us back full circle to why immediate identification and reversal of coagulopathy is absolutely non-negotiable from minute one.
Okay, so initial stabilization is underway, airways secure, patients positioned, resuscitation fluids and maybe blood are going, coagulopathy is being addressed. Now we enter the diagnostic phase proper, and this absolutely demands immediate, seamless teamwork. Who needs to be paged stat?
Right away, you need to get pulmonology, interventional radiology, IR, and thoracic surgery on the phone, or activated through whatever rapid response system your hospital uses. Everyone needs to be aware simultaneously. Each service has a specific, time-sensitive role. Pulmonology handles the acute airway management, the bedside bronchoscopy for clot removal, and initial localization, especially for central bleeds. IR is typically the first line for definitive vascular control via embolization, especially for those bronchial artery bleeds.
And thoracic surgery.
So surgery is the ultimate backup for bleeds refractory to other methods or for specific pathologies needing resection. Getting them involved early allows for planning, even if they don't operate immediately. While this team is mobilizing, we need rapid labs.
Yeah.
CBC, full copags, PTINR, PTT, fibrinogen, a type and crossmatch for blood products, and a comprehensive metabolic panel. Time is critical for transfusion planning.
Let's talk imaging. We know the initial chest x-ray gives us that mortality risk assessment based on quadrants involved. But for actually planning definitive therapy in a patient who is stable enough, the ACR guidelines are clear on the preferred modality.
Absolutely. The preferred imaging study in any patient who is stable enough to actually travel to this scanner is computed tomography angiography CTA. Ideally, a multi-phase CTA performed with specific vascular protocols designed to highlight both the bronchial and pulmonary arterial systems.
Why CTA over just a standard chest CT?
CTA provides far superior anatomical detail of the vasculature. It can directly identify those hypertrophied, tortuous bronchial arteries. It can spot vascular abnormalities like AVMs or pseudoaneurysms. And crucially, it gives IR the precise anatomical roadmap they need to plan and execute bronchial artery embolization safely and effectively. Plus, CT in general is more sensitive than bronchoscopy for picking up underlying parenchymal disease or malignancy that might be the root cause.
Okay, that brings up a really practical, critical question for our colleagues listening, maybe in the ED or the ICU. How do you define stable enough for the CT scanner? If a patient is requiring significant pressor support, maybe borderline on needing intubation, is the risk of that trip down the hall acceptable?
That is the ultimate clinical judgment call, isn't it? A real line-in-the-sand moment. If the patient is not intubated, if their oxygenation is marginal, even on high-flow oxygen or non-invasive ventilation, if they're hemodynamically unstable requiring escalating pressors, or if they are actively, massively hemorrhaging right now, they are not stable enough for the CT scanner, full stop.
So what do you do then?
In that scenario, the next step is immediate, bedside, urgent bronchoscopy. That becomes your primary diagnostic and initial therapeutic tool. However, if the patient is intubated and ventilated, if their vital signs are relatively stable, maybe on low-dose pressors but not escalating, and they aren't actively exsanguinating at that moment, then the diagnostic yield of the CTA, which is what guides the definitive therapy, BAE, likely outweighs the risks of carefully monitored transport. We often advocate for getting that initial portable chest x-ray, and then, if stability permits, moving quickly to the CT scanner with the IR team already alerted and standing by.
Makes sense. So what then is the specific role of bronchoscopy in this pathway? We know CTA is better for the peripheral vessels, but bronchoscopy seems indispensable for airway control and central issues.
Exactly. Bronchoscopy, usually flexible fiber optic bronchoscopy, is indicated urgently in those unstable patients, as we just discussed, for both diagnosis and immediate therapy. Functionally, it's our best tool for clearing the airway, suctioning out those large, life-threatening clots that are obstructing breathing. It also allows for rapid localization if the bleeding source is proximal within the central airways.
And once you find a central source,
Then you can potentially apply temporizing measures right then and there through the scope. While it definitely struggles to visualize bleeding sources distal to the subsegmental bronchi, that's where CTA shines, it excels at assessing and potentially controlling central airway lesions, like a tumor eroding into a bronchus.
you mentioned therapeutic bronchoscopy, these temporizing measures. What are the main techniques used bedside while maybe waiting for IR to get set up?
Probably the most effective temporizing technique is endobronchial tamponade using balloon catheters. This can be done with something as simple as a Fogarty embolectomy catheter or more specialized bronchial blockers. You advance the catheter down the bronchoscope's working channel, identify the bleeding segment or subsegment, and inflate the balloon right there to apply direct pressure to the bleeding source. It can be highly effective for temporary control.
Like putting a finger in the dike.
Pretty much, yes. We also use topical hemostatic agents. Topical tranexamic acid, TXA, is increasingly used. You can deliver it either nebulized before the procedure or instill it directly through the scope onto the bleeding site to help promote clotting. Older techniques included iced saline lavage, the cold, causing vasoconstriction, or even topical vasoconstrictors like epinephrine, usually diluted, applied very focally. Their effect on truly massive hemorrhage is probably limited, but they can help with smaller, oozing central sources.
So it sounds like the best approach, giving the highest diagnostic accuracy and therapeutic potential, really comes from combining both modalities. CT maps the vessels peripherally, bronchoscopy manages the airway, and deals with central problems.
Absolutely. That's the modern standard of care. They are complementary, not mutually exclusive. We rely on CT-CTA to identify that high-pressure bronchial artery source that usually needs embolization by IR, and we rely on bronchoscopy for the real-time airway management, clot evacuation, and immediate control of central bleeding. Neither tool alone gives you the complete picture or covers all bases in massive hemoptysis.
Okay, let's move into definitive management strategies. Stabilizations happen, localization is as good as we can get it. Now it's about stopping the hemorrhage for good. And you mentioned this follows a pretty clear tiered approach.
Yes, and the top tier, the preferred first-line definitive intervention for the vast majority of massive hemoptysis cases, especially those coming from the bronchial circulation, is bronchial artery embolization, or BAE. It has really indisputably emerged as the go-to initial therapy.
Why has BAE become so clearly superior to just taking the patient straight to surgery, which might have been the approach decades ago?
Yeah, the main reasons really boil down to patient physiology and procedural risk. BAE is minimally invasive. It's usually done under conscious sedation, not general anesthesia. It avoids the massive physiological stress of a thoracotomy, opening the chest, in a patient who is often already critically ill, hypoxemic, maybe unstable.
And it works well.
It works remarkably well. Immediate hemostasis success rates are consistently reported as very high, often in the range of 75% to 98%. And crucially, multiple studies and major societal guidelines like ACCP and ACR confirm that BAE is associated with significantly lower mortality and fewer complications compared to doing early emergent surgery for massive hemoptysis. It allows the patient to stabilize first.
Making surgery safer if it's needed later.
Exactly. If surgery is ultimately required, BAE buys time to optimize the patient, making it a planned elective or semi-elective procedure on a patient with much better physiological reserve, which dramatically improves outcomes.
Let's dive a bit deeper into the BAE procedure itself. What exactly is interventional radiology targeting, and what are the key risks that we, as the referring physicians managing the patient before and after, really need to be aware of and monitor for?
So the IR physician is using angiography to visualize the thoracic aorta and its branches. They're looking for those hypertrophied, tortuous bronchial arteries that often show up as hypervascular blushes on the angiogram, indicating the likely source. They then use tiny microcatheters, guided under fluoroscopy, to selectively navigate into these abnormal bronchial arteries.
And then they block them off.
Right. They deploy embolic agents through the microcatheter to occlude the bleeding vessel. These agents can be tiny particles like PVA particles or gelatin sponge or metallic coils, or sometimes even liquid embolic agents like glue. The goal is to block flow to the bleeding site while preserving flow to normal lung tissue as much as possible.
And the major risks.
The most feared, though thankfully rare, complication is non-target embolization. Because the bronchial arteries share origins or have connections with other arteries in the chest, there's a risk that some embolic material could travel unintentionally to the wrong place. The most critical one we worry about is the anterior spinal artery.
Which supplies the spinal cord.
Exactly. Particularly the artery of Adamkiewicz, which is a major supplier to the lower thoracic spinal cord, and often arises from an intercostal artery that might share a common trunk with a bronchial artery.
And the consequence, if that artery gets embolized,
it's catastrophic. Spinal cord ischemia leading to paralysis, paraplegia. It's devastating. Now, IR teams are acutely aware of this risk. They use very careful techniques, super selective catheterization, detailed angiographic road mapping, sometimes even provocative testing with lidocaine to identify spinal artery feeders before embolizing. But we, on the inpatient side, need to know this risk exists, monitor neurological status closely post-procedure, and react immediately if deficits develop. Thankfully, the actual risk is low, usually quoted as less than 1 or 2% with modern techniques, but it's not zero.
Okay, so BAE is the primary definitive therapy. But bronchoscopic interventions still have a role, especially for central lesions and, as we discussed, as temporizing or bridging measures.
They absolutely do. If you have a clearly visible bleeding source in a central airway, maybe an endobronchial tumor that's bleeding, or a tear, direct intervention through the bronchoscope might be the fastest way to achieve control. We already mentioned endobronchial tamponade with balloons, but for focal lesions, we can also use advanced thermal therapies.
Like pottery.
Essentially, yes. Things like the endo-IAG laser, argon plasma coagulation, APC, or standard electrocautery can be applied directly to the bleeding site through the scope to achieve local coagulation and seal the vessel. The choice really depends on the lesion type, the location, the available equipment, and frankly, the expertise of the pulmonologist performing the procedure.
Okay, BAE first. Bronchoscopy for central temporizing. When does surgery, lobectomy, or even pneumonectomy become the necessary option?
Surgery is really reserved for pretty specific, limited situations these days. The main indications would be, first, truly localized disease where the bleeding is persistent or recurrent despite adequate attempts at BAE and maybe bronchoscopic control. Second, when there's an underlying structural pathology that simply requires surgical resection for cure or definitive control.
For example?
Things like a large, complicated pulmonary AVM that's not amenable to embolization. Certain types of major vascular trauma involving pulmonary arteries or veins, or that refractory aspergilloma we talked about, where the fungus ball and the chronically infected cavity are the ongoing source, and embolization just can't get durable control because the whole area's vasculature is deranged.
And you stressed earlier that rushing into emergent surgery is dangerous. Can you elaborate again on why delaying surgery after initial stabilization is so much better?
Yeah, just imagine trying to do an urgent pneumonectomy, removing an entire lung on a patient who is hemodynamically unstable, profoundly hypoxemic, with their airway full of blood. Visibility in the surgical field is terrible, the patient's physiology is incredibly fragile, and the stress of the surgery itself is immense. The mortality rates for emergent reception and massive hemoptysis are historically very high.
So BAE buys that time.
Exactly. The goal of BAE, or sometimes effective bronchoscopic tamponade, is to stop the immediate life-threatening bleed. Let the patient recover. Let their lungs clear the aspirated blood. Optimize their oxygenation, their nutrition, their coagulation status over days or even weeks. Then, if resection is still indicated, you perform it as a planned elective or semi-elective procedure in a much more stable patient. That approach dramatically improves outcomes compared to the crash and burn scenario of emergent surgery.
Makes perfect sense. We've covered the big invasive management strategies, but the medical therapies and adjunctive support around these procedures are just as vital. Starting again, you can't say it enough, with fixing the coagulopathy.
It's the absolute cornerstone of supportive care. needs to be initiated before you even know the source and monitored continuously. Beyond reversing warfarin and DOACs, you have to aggressively treat any underlying bleeding diatheses. That means maintaining adequate platelet counts, keeping them above 50,000, maybe even higher, above 100,000 in this setting, ensuring adequate levels of vitamin K-dependent factors if there's liver disease, checking for and treating things like DIC, disseminated intravascular coagulation, if suspected.
Now, let's talk about antifibrinolytics again, specifically tranexamic acid, TXA. Its use in nebulized form has certainly gained a lot of interest, but what's the hard evidence for using it in truly massive hemoptysis?
That's a really important point of clarification. Nebulized TXA, typically given as 500 milligrams, maybe 3 times daily, has shown some very promising results in studies looking at non-massive hemoptysis. The evidence there suggests it can lead to faster cessation of bleeding, reduced duration of bleeding, and maybe even a reduced need for subsequent invasive procedures like BAE or bronchoscopy in those less severe cases.
But for the unstable, massive bleed.
Right. And this is crucial for everyone listening. Current high-quality evidence, like large randomized controlled trials, has not yet established nebulized TXA as a primary definitive therapy for unstable massive hemoptysis, nor has it demonstrated a clear mortality benefit in this specific high-risk population.
So how should we view it then?
We should view it as a potentially valuable adjunctive or temporizing measure. Maybe it helps slow the bleeding while IR is mobilizing or while you're getting ready for bronchoscopy. Perhaps it helps stabilize clots after BAE. But it should never be seen as a replacement for definitive hemorrhage control with BAE or surgery when indicated, or as a substitute for immediate airway management. We still need more robust, adequately powered studies to really define its role in the massive, unstable scenario. Use it perhaps, but don't rely on it alone.
Got it. Okay, so the definitive intervention, usually BAE, sometimes bronchoscopy has been done. The bleeding seems controlled for now. But the risk isn't over, right? Continuous high-intensity monitoring is critical because recurrence is common.
Absolutely paramount. The highest risk period for rebleeding is typically within the first 24 to 48 hours after the intervention. That's why these patients absolutely require continuous cardiorespiratory monitoring, heart rate, rhythm, blood pressure, respiratory rate, and continuous pulse oximetry. They must be managed in a monitored setting, usually in ICU, or at minimum, a very high acuity step-down unit with appropriate staffing ratios.
And labs.
Serial labs are essential. Hemoglobin and hematocrit to track ongoing blood loss or hemodilution. Coagulation profiles to ensure any coagulopathy remains corrected. We need to guide ongoing blood product transfusions based on these labs and the clinical picture. We also need to maintain pretty tight control over blood pressure, avoid significant hypertension that could potentially blow off the fresh embolization or clot.
What about follow-up imaging during this critical monitoring period?
Yes, post-intervention imaging is usually necessary. Typically, at least a repeat chest radiograph within 24 hours, and often a repeat CT scan at some point, maybe not immediately, but within a few days, or if there's clinical concern for rebleeding. We're looking for a few things. First, resolution of those pulmonary opacities basically is the blood clearing from the alveoli, indicating lung recovery. Second, we're looking for any post-procedural complications, things like a new pleural effusion, pneumothorax from barotrauma perhaps, or signs suggestive of non-target embolization if BAE was done. And of course, we're looking for any new consolidation that might suggest rebleeding. Multidisciplinary rounds involving IR, pulmonology, thoracic surgery if involved, and the ICU team remain absolutely crucial during this period to coordinate the ongoing plan.
Okay, let's wrap up by touching on the complications and the, frankly, stark reality of the overall prognosis. We mentioned non-target embolization with BAE. What about the risk of rebleeding after BAE? Why does that happen?
Right, so aside from the immediate risk of spinal cord ischemia or other non-target events, the more common longer-term issue after BAE is rebleeding. It's reported to occur in roughly 10 to 20% of patients, sometimes more, depending on the underlying cause. This usually happens for one of two main reasons.
Okay.
First, incomplete initial embolization. Maybe the primary feeding vessel wasn't fully occluded, or maybe there were multiple feeders and one was missed. Second, and very commonly, collateral vessel recruitment. The body is remarkably good at finding alternative pathways. If you block the main bronchial arteries over time, systemic collateral vessels from adjacent arteries like the subclavian, the internal mammary, other intercostal arteries can enlarge and effectively take over the blood supply to that same area of diseased lung, leading to renewed hemorrhage weeks or months down the line.
So re-embolization might be needed later.
It often is, yes. Recurrent hemoptysis after BAE frequently requires repeat angiography and embolization of these newly recruited collateral vessels.
And quickly, complications from therapeutic bronchoscopy.
Bronchoscopy itself carries risks like airway trauma during insertion, potential for introducing infection, triggering bronchospasm, specific to the therapeutic maneuvers. Prolonged balloon occlusion during tamponade, if left inflated too long, can potentially cause pressure necrosis of the bronchial wall, so the duration needs careful monitoring. Thermal therapies like laser or APC carry a small risk of airway fire, especially with high oxygen concentrations, or perforation if used too aggressively.
And surgery, as we've said, carries significant risks, especially emergently.
Yes, major perioperative risks, including respiratory failure, especially after pneumonectomy, persistent air leaks from the bronchial scump or lung parenchyma, infection like empyema, bleeding, all significantly higher in the emergent setting on an unstable patient.
So given all these complexities, the potential for recurrence, the risks of intervention, what does the overall mortality picture look like for massive hemoptysis today, even with all these advanced techniques?
Despite everything we can do, mortality rates unfortunately remain high. They're typically reported in the range of 20% to maybe 38%, depending on the study population and definitions used. It's still a very lethal condition. And that stark figure really underscores the fact that death is almost always due to that rapid asphyxiation early on. It highlights the absolute time sensitivity of securing the airway and initiating control measures.
And prognosis varies based on the cause.
Absolutely. Prognosis is undeniably worse in patients who have extensive underlying lung disease, limited pulmonary reserve, or particularly those with underlying malignancy as the cause. As we mentioned, mortality in cancer-related massive hemoptysis can approach 60% to 100% in advanced cases. The patient's overall physiological state and the underlying reason for the bleed are probably the strongest predictors of survival.
So boiling it all down, the core message for our listeners seems crystal clear. Massive hemoptysis is fundamentally an airway emergency. Priority 1 is immediate stabilization, securing the airway, and using lateral positioning with the bleeding lung down if it's localized. Then we rely on urgent CTA in the stable patient to guide the definitive procedure, which is preferentially bronchial artery embolization. Surgery is reserved for very specific, localized, or refractory disease, and ideally should be delayed until the patient is stable whenever feasible. And throughout all of this, aggressive reversal of coagulopathy and continuous high acuity monitoring are absolutely non-negotiable.
That summarizes the tiered approach, the algorithm, perfectly. Our management structure has to be built for speed and stabilization and accuracy and localization to facilitate BAE as quickly and safely as possible.
Okay, so that brings us to a final thought, maybe a provocative question for everyone listening to consider within their own institutions. Given the clearly superior safety profile, the high success rate, and the established first-line status of bronchial artery embolization, how can we, as hospital leaders, as clinicians on the ground, critically analyze and maybe streamline our own multidisciplinary protocols to ensure that interventional radiology access for emergent BAE is truly available 24 hours a day, 7 days a week? Not just available on call, but rapidly mobilized and in practice. If patient survival hinges on getting that embolization done quickly, we really need to look hard at our institutional resources and response times for activating emergent BAE. Are they adequate?
That's a vital point for systems-level improvement, because ultimately, timely access to that specialized IR resource is often what dictates the outcome in these incredibly sick patients. It requires ongoing auditing of our internal processes, simulation, and constant adjustment to minimize delays in getting patients the definitive care they need, a crucial takeaway.